Hi everyone. Thanks very much for the invite to come and talk today. I have to say I've got somewhat imposter syndrome. Everyone else has travelled a long way to be here, either physically or virtually, but I've only come 10 miles down the road from Leicester. So apologies for that, but hopefully I'll have something interesting to say. So my name's Tom Ward. I'm a respiratory physician and a clinical lecturer at the University of Leicester. And my interest is on respiratory disease and exercise interventions for people with respiratory disease, specifically COPD, chronic obstructive pulmonary disease. So I wanted to start by taking you back to basics and thinking about when we exercise. What do we need to get oxygen from the air to the exercising muscles and carbon dioxide back out again? Well, we need a functioning airway to get air into the lungs. We need lungs that work, that move air in and out, and that are able to allow gas exchange. Then we need a cardiovascular system which moves that air from the lungs to the exercising muscle. And then we need gas exchange to happen at the muscle level. And we need hemoglobin to carry the oxygen in the bloodstream. So I then wanted to take you on to try to give you some understanding of what it's like for someone with significant respiratory disease, significant lung disease, when they exercise. How do they feel? Because when most of us exercise, and even at high levels like Kipchoge here, we still have extra capacity in our lungs. So even at maximal exercise, we can take bigger breaths and we can increase our respiratory rate. But when you've got lung disease, that's not the case. So it's the lungs that stop people with lung disease. This patient here has COPD and is trying to walk. And it's the lungs that stop her doing more. And so what does that feel like? Well, it's very difficult for us to understand when we haven't been in that situation. We've never been in a situation where it's our lungs that are stopping us exercise. And so I think the best way to imagine that is to think about if you're underwater and if you physically couldn't take a breath in, there was no air available. I think the natural response in that situation is to panic and to have that sympathetic drive, that flight or fight response to say, look, I need to get some air in. And so that's what people with significant lung disease, COPD and other respiratory diseases feel every time they try to do some exercise. So even something as simple as walking, something we take for granted, is associated with that significant symptom of breathlessness and the associated psychological factors that come with it. And that naturally leads people with respiratory disease to avoid exercise. Why are you going to put yourself in that situation where you experience that severe level of breathlessness? And so people with lung disease tend to be inactive. And that leads to worsening skeletal muscle function. And then when they try and exercise next time, that breathlessness happens at an even earlier level because of associated skeletal muscle dysfunction alongside their respiratory disease. And they get caught in this vicious cycle of increasing breathlessness, worsening physical inactivity, and worsening exercise limitation, which then worsens their breathlessness. And that's impacted by acute worsening of symptoms that we call exacerbations. So what do we do about that? One more slide before I come on to that. COPD and other respiratory diseases end up not being just a disease of the lungs. So yes, the primary issue is ventilatory limitation for a variety of reasons. But then you get skeletal muscle dysfunction, you get impaired heart function, cardiac function, and there's associated central nervous effects. Anxiety, which I don't think is a comorbid condition, I think is a symptom of being breathless. It's a natural evolutionary response to get anxious when you have that significant sensation of breathlessness. And that leads to low confidence and motivation of doing activity. So what do we do about this? Well, we try and break that spiral of deconditioning by getting people to exercise. And hopefully I've given you some idea that can be a hard sell. You're getting people with significant respiratory disease to and asking them to not only experience that sensation of breathlessness, but do it again and again, 3 times a week, week after week. But why do we do it? Well, it works. So not only does it improve how far they can walk, it improves their quality of life, and it improves their breathlessness. So we have to, when I have a patient in front of me in clinic, I have to say, look, you're not going to do any damage to yourself by exercising, by getting out of breath. Actually, in the long run, your breathlessness will improve if you do that. And actually, the sell is even harder than that, because it may not be enough just to do any activity or any exercise. If you really want the maximum gains in terms of breathlessness, in terms of exercise capacity, it's probably high intensity exercise that's the most beneficial. So we're asking patients not just to exercise, but to exercise at a high intensity. So this isn't a new idea. We prescribe this exercise for people with lung disease in the form of something called pulmonary rehabilitation. And this idea has been around since the 1950s, and actually the first definition in America was published in 1974. And we have so much evidence of the effectiveness of exercise training in COPD that in 2015, Cochrane review concluded that no further evidence was needed. We didn't need more randomized controlled trials of exercise versus usual care in COPD. But we've still got some work to do. And I think a lot of it comes down to this issue of breathlessness and the significant symptom that people get when they try and exercise. And that means that even if somebody is referred to a program, pulmonary rehabilitation, actually only a minority of them attend that program, and only a minority complete. So from every 100 patients that's referred to pulmonary rehab in the UK, only 42% of them complete the program. And there are issues even before that stage with the acceptance of that this intervention within referrers. So what can we do to try to improve exercise training for people with lung disease and improve adherence rates to these exercise programs? Well, these are some of the exercise modalities that we have looked at and are looking at. So first I'm going to talk about eccentric cycling. So we generally think of muscle movement, and many of you will know this, in terms of concentric contraction, so muscle shortening producing force. But muscles produce force during lengthening, and that's known as an eccentric contraction. And what we've shown is in COPD, and the same happens in health, for matched mechanical load on the exercising muscles, the oxygen requirement is much lower during eccentric exercise. So can we use this for people with advanced lung disease to either make exercise more tolerable, because it doesn't lead to that significant breathlessness, or can we increase the training load so we get enhanced gains from a program of exercise training in this population? So we've got this bike which we've used, which is a modified bike. It's got a motor just on the back that rotates the pedals in reverse, and our patients have to push forwards to slow the pedals down and exercising their quadriceps eccentrically. The other modality that we've looked at is one-legged cycling for similar reasons, although different mechanisms. So in one-legged cycling, instead of cycling as we normally would do with 2 legs, we just use 1 leg, and that halves the exercising muscle mass. So for people with a ventilatory limit to maximum exercise, if you're exercising 1 leg at a time, you can perform higher muscle work on the individual leg before you reach that ventilatory limit. So you could use that to match the workload and therefore make the exercise more tolerable and induce less breathlessness, or you can increase the training load to produce more stimulus to the exercising muscle and therefore greater adaptations in terms of exercise capacity and breathlessness for patients with lung disease. And it's probably not the solution for all of our patients. Pulmonary rehab works really well, and we've got lots of evidence it works really well. But there's a subset for whom it probably doesn't work, and for whom we need alternative exercise modalities. So this is a study where we simply got people to do a two-legged maximal exercise test and then a one-legged maximal exercise test, and looked at the ratio in terms of their peak workload between the two. And actually those with lower ratio, so they were, when you remove that ventilatory limit, actually the exercising muscle, the leg, wasn't able to do any extra work. When you when they enrolled on the training program of either traditional cycling training or these novel exercise modalities of eccentric training or one-legged cycling, it didn't really they weren't able to produce they weren't able to do extra work, so there didn't seem to be any added benefit in that population. For those with a higher ratio, for whom when you exercise one leg at a time, they were able to do significantly more, they were then, in the training program, able to do significantly more. So there's probably a subset of our patients for whom these novel exercise modalities are beneficial. And very briefly, this is something we're looking into at the moment, but I don't have any data yet. So this is blood flow restricted exercise. So a cuff around the exercising muscle, the leg, to stimulate oxidative stress and potentially induce adaptation with low exercise intensity without that significant sensation of breathlessness. So I think, in summary, we're doing a good job for our patients in terms of improving their breathlessness with exercise, but I think there's more that we could do to really target our interventions to individuals. Thank you very much.